I think we'll get started. We're a couple minutes after the hour. Thanks again for everybody who's attending. Happy Thursday to everyone. I know it's the lunch hour here on the East Coast, so hopefully you're enjoying lunch while you're listening to our webinar on code shopping and why it is not ideal for your reimbursement strategy. Before we get started, I want to introduce PRIA. PRIA is a full-service reimbursement consulting firm to the MedTech industry. We have services that range from early strategic product planning all the way through commercialization and assistance in patient access programs. So here today with me, I have my esteemed colleague Jennifer Saab and myself, who will introduce in a minute. And one other item I did want to indicate, as we're going through the presentation, if you could please, any questions you have, just put them in the chat. We will address them at the end of this as well. But if you could hold questions until the end or put them in the chat, that would be great. So a little bit about myself. I'm Tonya Dowd. I'm the Executive Vice President of Reimbursement, Value Generation, and Market Access here at PRIA. I have over 25 years of experience doing reimbursement, market access, and early commercial stage planning for new and novel technologies across multiple disease areas. I've worked in biotech or with biotech technologies, molecular diagnostics, medical device, including DME and digital health. And I have about 12 years of experience with J&J. I am a judge for MedTech Innovator, and I'm a consultant for multiple biodesign programs across the country. And I'm also a consultative board member for the International Society of Cardiovascular Translational Research. Jennifer, did you want to go ahead and introduce yourself?
Sure. Hi, everybody. Nice to see everyone today. My name is Jennifer Saab. I am PRIA's Senior Director of Reimbursement, Value Generation, and Market Access. I have 15 years of experience in market access and reimbursement. I have helped companies from inception to successful commercialization and beyond to really secure their coding, coverage, and payment. I am a certified outpatient coder and a certified professional medical auditor.
Thank you, Jennifer. And we are thrilled to have Jennifer Saab with us as a certified coder and really as an expert on the coding discussion we'll have today. So our learning objectives for today are really to understand the various code sets in the US, what their purpose is, who oversees these code sets, and their interrelation to different payment methodologies specific to Medicare, because that is the publicly available and often referenced fee-for-service mechanisms in the country. We're going to define what CPT code shopping is and the potential impact for innovative technologies. And we're going to identify opportunities and considerations for establishing unique CPT codes, understanding the proper code vetting pathways and other helpful resources, and some key takeaways. And although we're going to cover and speak to the multiple different code sets that are used in the US, the content of this specific webinar will just focus on CPT, current procedural terminology coding, just so everybody is aware. So setting that stage. We always want to ground ourselves in really the fundamentals of reimbursement. So really looking at the three pillars: coverage, coding, and payment. And I'm going to add another one, and that's benefit category. And we'll get to that in a second. But really, in terms of the foundation, we want to make sure that we have positive coverage from third-party payers. And what that means is, do the third-party payers, Medicare, commercial payers, Medicaid, workers' comp, do they really, do they have medical policy in place that deems the technology to be reasonable and necessary or medically necessary for a very specific patient population, always based on published data that supports that indication and the use of that technology? So that's really important to understand. And that's really the foundation of these fundamentals. Payment, it's really the methodology, the amounts that are assigned or provided to a healthcare provider, either a facility or a physician. We're going to focus on those two entities today, based on the payer type and the setting of care, and again, the benefit category. So payment mechanisms are definitely impacted by the benefit category we're speaking of. And then finally, coding. That's the alphanumeric identifier used for procedures, devices, drugs, and supplies that are submitted on a claim form by a healthcare provider to a third-party payer for payment. And again, just kind of the overarching umbrella here is the benefit category that your technology is going to fall into. Is it a durable medical equipment product? It will be subject to different coding mechanisms and payment mechanisms than a procedure that's done in the hospital, for example. Or is it a physician-administered drug? So really understanding that benefit category is very important in terms of really driving the three pillars: coverage, coding, and payment for reimbursement. Just provide an overview of the different coding mechanisms that are used in the US. We have, again, CPT, current procedural terminology, that's used for physician payment and hospital facility payment. We have HCPCS, or Healthcare Common Procedural Coding Systems, for device billing or supplies, and also physician-administered drugs. And we have ICD-10 diagnosis codes, and also ICD-10 procedure codes. And really delineating where these are used and how they're applicable is important. So understanding that with patient diagnoses, those are used across all care settings and by all healthcare provider types. Physician offices, that's using CPT codes and HCPCS codes, and again, ICD-10 diagnosis codes. Procedures that are done in the hospital setting, we're using ICD-10 procedure codes and, of course, diagnosis codes. And then hospital outpatient, we're using CPT, HCPCS, and, of course, ICD-10 diagnosis codes. So understanding the utility of the different code sets, where they're used, is very, very important, again, in understanding what that reimbursement and coding strategy is. So top of mind for everyone on this program, what is code shopping? And if you Google it, you probably won't find a definition. But really, at its core, what code shopping is focusing the reimbursement strategy, which again should be holistic in terms of looking at what is the coverage plan, what is the payment mechanism, what are the codes that are applicable to the technology. But really focusing the reimbursement strategy on identifying a code, one code only, and identifying a CPT code for a new medical technology, either a procedure, device, diagnostic, digital health tool, through online platforms such as Google, ChatGPT, so using AI, talking to physicians who are are using your product, maybe your PIs, or the CPT book. So literally going in and looking at and identifying a code that might fit a descriptor that sounds like your technology. So basing that solely on the descriptor or published Medicare average payment, and this is really important, without consideration of what is the technology, what is your technology's value? What value is it bringing to the relevant stakeholders in terms of maybe reducing cost, maybe it's increasing a clinical outcome, a more positive clinical outcome. How much work is required of the physician? When we talk about digital health therapies, they're oftentimes AI is the actual work that's being done, and there is no physician work. So really understanding what is that physician work, and we're going to go over the components of that later in the slide deck, but really understanding what that work is and what the technology's pricing and business model is, and the reimbursement rules that apply to the different code structures and the reimbursement rules that apply to that payer. And we're going to go over those in a bit. And really just not having and considering a holistic and well-informed reimbursement strategy. And if you remember nothing else from this presentation today, it is this: simply having a code does not guarantee coverage or reimbursement for your technology. And we'll repeat that again, so everybody is well aware of that. It will be something you won't forget after this session. And just to drive home this point and to support this point, this is a section from the CMS Medicare manual that states just this: the fact that a drug, device, procedure, or service is assigned a code, either a HCPCS code or CPT, and a payment rate under the hospital outpatient prospective payment system or the inpatient system, and we'll go over those in a minute, does not imply coverage by Medicare, but indicates only how the product, procedure, or service may be paid if it's covered by the program. So remember earlier I talked about the three key components: coverage, coding, and payment. You have to have all three to have successful reimbursement. So who are the oversight bodies in the US for different code sets? And this is really important because it's not just one oversight body who establishes codes, manages the code sets, but it's a potpourri of different organizations. So for ICD-10 diagnosis codes, those are overseen by CMS, the Centers for Medicare and Medicaid Services, and the CDC. Conversely, for CPT codes, those are managed and actually trademarked by the American Medical Association. They describe the procedure or the service. Again, going to ICD-10 procedure codes, those are overseen and assigned by CMS. And then finally, for HCPCS codes, those are overseen and assigned by CMS, in particular, the CMS HCPCS coding work group. So it's very, very important, again, to understand truly who's overseeing the different code sets and, again, what purpose each of them are used for. I highlighted the CPT here in red because, again, we will be focusing on just CPT for today's session. So what are CPT codes? They are, again, current procedural terminology codes, a series of numeric codes used for reporting medical services and procedures by healthcare providers, either facilities or physicians. They are used by physicians, clinics, ancillary providers, hospital outpatient departments, ambulatory surgery centers for physician and outpatient payment. There are approximately 12,000 CPT codes to date, and the American Medical Association manages and updates these codes annually. And the AMA has very specific criteria for granting new codes for physician procedures. So there are essentially three different types of CPT codes, kind of starting from the top going down. Unlisted codes, which are really used as a catch-all or placeholder temporarily, oftentimes for new and novel technologies that don't have other coding methodologies. So they can be, the great thing about it is they can be used immediately. And the bad thing about it is you can't necessarily track your procedure and the utilization of your procedure with an unlisted code. It also has no payment assignment, so it is carrier priced or payer priced. So that's the negative. But unlisted, there's codes to use. 76999 is an example. Moving to category 3, they represent new and emerging technology. And about 90% of new and emerging technologies begin with a category 3 CPT code. You do not have to have FDA approval or clearance or broad utilization for category 3 codes to be assigned. They are often used strategically and assigned strategically to be used in clinical trials for tracking purposes, or if there's a payment assignment and the PI site is actually submitting for payment, they can be used for that. Just like unlisted CPT codes, there is no payment assignment for category 3 CPT codes for the physician. Under Medicare, there is a payment assignment, and that is negotiated with CMS for the payment assignment under the outpatient prospective payment system. These are assigned every 6 months, again, by the AMA. In an example of a category 3 code, it has a T appended on it for tracking purposes, again, because it's for tracking purposes of new and novel technologies. Category 1 CPT codes are the holy grail. That's what everybody wants to have. It means that the technology is ready for prime time. The technology has society support. It has broad utilization and adoption in the marketplace. The clinical effectiveness is documented and published in the peer-reviewed journals. You have to have up to 5 peer-reviewed journals. That's a requirement. To obtain a Category 1 CPT code, you have to have society support. There is a payment assignment for Category 1 CPT codes, and we'll get into that in a minute. And that's why it's an 18 to 24-month process to actually establish a Category 1 CPT code, because it goes through the RUC process, the Relative Value System update process. An example of a Category 1 CPT code, 63450. So it's important to look at, as we dig into CPT codes, who's involved in establishing CPT codes, right? So the CPT ecosystem, just at a high level, consists of CMS, the American Medical Association, the MedTech industry, so the MedTech innovators who want to be involved and are working with their relevant specialty societies to establish CPT codes, healthcare providers, and the AMA, specifically the AMA editorial panel and RVS update committee, or the RUC. So let's look into details in terms of the ecosystem and roles that each of these entities play in the assignment of CPT codes. So the AMA editorial panel oversees and maintains CPT codes. They ensure that adherence to the specific criteria, I mentioned that earlier. You have to have society support, clinical data, broad utilization, but they make sure that the technologies that are coming through that need new codes, or that are going to a Category 1 CPT code, are meeting that criteria. They provide uniform language that accurately describe the procedure and medical services, and they meet throughout the year, February, May, and October. And those meetings are actually public, and you can attend those in various parts of the country. The AMA RVS Update Committee, or the RUC Committee, suggests relative value units, and we'll get to what relative value units are in a minute. But they suggest RVUs and assignment for CPT codes that equate ultimately to payment for that code, for the physician specifically. And they're responsible for describing the resources required to provide physician services with CMS, who considers those RVUs when assigning payment. Specialty societies, there's representatives from nearly all specialty societies on the AMA editorial panel, and they represent their respective disease sections in CPT. They are also involved in that editorial panel and RUC processes. And then finally, CMS. So CMS funds and manages the physician fee schedule, and accepts the RUC's recommendation or doesn't accept the RUC's recommendation. So CMS plays a big role in that they may or may not accept the RUC's recommendation of what the RVUs should be for that CPT code that would equate to payment. So they assign, again, RVUs, final RVUs, they have the final say, and they also manage the hospital outpatient prospective payment system and assign CPT codes to categories for facility payment. So you can see there's various players here that play a role and that are involved in the CPT process. So looking at the CPT code sets, where they're used, how they're used, and the interrelation to payment is really important as well. So if we look at CPT codes in the physician offices, the management and oversight body is the AMA, and the payment method is the physician fee schedule, again, which uses relative value units. The payment oversight agencies, again, are the AMA, RUC, and CMS. In the hospital outpatient department or ambulatory surgery center, again, the oversight body is the AMA, and the payment methodology is the outpatient prospective payment system that uses ambulatory payment classification groups to assign CPT codes to APCs that have a payment. And the payment oversight agency is CMS. So really understanding these players and how they actually operate and assign payment is very, very important in your coding, payment, and coverage strategy. So digging into the Medicare Physician Fee Schedule, PFS, which uses RVUs, It's based on relative value units that are assigned to Category 1 CPT codes. Again, remember that Category 3 and unlisted CPT codes do not have assigned RVUs. Those are carrier priced. RVUs will differ based on the setting of care. So if we move from left to right in the depiction here, you have always a physician work RVU, and that determines how much work, how much skill and time, stress, does it take the physician, he or her, to perform that service. There's an RVU for practice expense, and that is bifurcated further into non-facility practice expense and facility practice expense. So the idea here is, what is the overhead? What is the supply cost inclusive of the actual device itself in order to perform that service? The non-facility, if there's a non-facility practice expense RVU, is often higher because the physician is assumedly purchasing the technology to be used in his or her office, okay? If they're doing it in the facility, it's lower. And sometimes there isn't a non-facility practice expense RVU because the technology is not done or performed necessarily in a physician office. And then you have the RVU for practice expense, which really is determined by bodies that we can't affect, essentially. All of those RVUs are added up and multiplied by a conversion factor that CMS sets on an annual basis, and that equates to the Medicare base payment. Now, it's important for innovators to understand that the Medicare base payment, 80% of that goes to a Medicare participating provider, and 20% of that payment is responsible. The beneficiary is responsible for paying what's called a co-insurance. So only 80% of that will go to the actual physician performing the service. But you can see how you dig into the specific RVUs and how these payments are assigned. It's very, very important to understand what that is. And again, if it's applicable to be done in an office setting or not. I am going to hand it over to Jennifer to talk about kind of switching gears to the hospital outpatient prospective payment system that I mentioned earlier, that again uses CPT codes, but this is how CMS actually pays hospital outpatient services. Jennifer?
Thanks, Tonya. Yeah, so when we take a look at the payment method for the hospital outpatient prospective system, often called, or you might hear it called OPPS, this is the payment methodology that CMS will use to reimburse technologies, devices, and procedures that are performed in the hospital outpatient department setting or the ambulatory surgical setting. The coding assignment with regards to the OPPS site of care will be under an ambulatory payment classification, or those APCs, and that's the main unit of payment that the OPPS follows. CMS will assign individual services using CPT or HCPCS codes to these APCs, right, based on having similar characteristics and cost association. With regards to payment calculation, the payment rate and copayment that is calculated for an APC applies to each service within that APC. Tonya, you can go to the next slide. One of the things that affects the payments within an APC group for that OPPS setting are what is called an NCCI edit, or status indicators, right? Status indicators they help to identify whether the service is described by the HCPCS code and paid under the OPPS, and whether that payment is made separately or packaged within a code. So the status indicator provides additional information about how that code is going to be paid or under another payment system or fee schedule. For example, status indicator A, with status indicator A, it is paid under fee schedule or payment system other than OPPS. Services with a status indicator N are paid under OPPS, but their payment would be packaged into a payment for a separately paid service. So you have the code, it has a status indicator of N, and the N means that it's already paid underneath another code or another APC. Services with a status indicator T are paid separately under OPPS, but a multiple procedure reduction payment rule will apply when two or more services with that status indicator T are billed together on the same date of service. A full list of the status indicators and the definitions are published in the Addendum D1 when CMS releases their proposed and final OPPS and ASC rules each year. And the status indicator for each HCPCS code are shown in the OPPS Addendum B, just so, as a reference on where to locate these. Tonya?
Sure.
One of the other considerations with regards to payment in the OPPS system is that multiple procedure reduction rule. And we thought we would give you an example today to see how when billing multiple codes together, it doesn't always equate to you're going to get full payment for each of those codes. Generally, what will happen is the code with the heaviest weighting and the highest work value will be paid at 100%. As you can see, 93306 in this example is paid at 100% because it has the highest unit paid amount at $227. So there's no reduction there. But every other code that's billed on the claim with the same date of service for that patient are only paid at 75% of the Medicare value. So it is something to consider when you have multiple codes billed together. It doesn't always mean you're going to get 100% of each of those codes, especially when you're dealing with that status indicator T.
Great points, Jennifer. So Jennifer, how should a company go about identifying and validating whether an existing CPT code is appropriate and fits their technology, or if they need to actually establish their own?
Well, there's several things to consider when trying to identify and validate a code. There are coding forums like the AAPC or American Hospital Association, AHA, that will help to identify codes. They give great examples of what is used in that codes, how the codes are developed and established. There's also special instructions and notations into the definitions of the codes and how they're formed, oftentimes called a vignette or an op note, right? That takes into consideration everything that would be done within that code in order for you to use it. The RVUs, as Tonya talked about earlier, they confirm and align with that technology and the associated procedure and practice expense. So that has to be taken into consideration. The work values have to match. There's also the specialty societies that need to be considered for engagement. These societies weigh heavily in development of CPT Category 3 codes and also Category 1 codes, right? So their engagement is very important as well. And it's very important with the payers, private payers and Medicare, because they take into consideration what their guidelines or what their experience or recommendations will be with these codes. There's also the AMA CPT knowledge base, and this is a great resource because it gives you background and history and recommendations for codes and everything that's been utilized within that code in the years since its development or establishment. We talked about the vignette, right? That's going to properly identify the procedures and how the technology is going to be used. And then really, as Tonya mentioned in the beginning, PRIA is a great resource because we can assist with the understanding of this ecosystem. It's quite complex, but we're the experts. We've been doing this a lot of years, and we can really create how the code is going to be how you should look at identifying what's proper, how to validate this. We also can look at the competitors in this space, the history of the code, where the societies stand and where the payers stand within that code for their product. So it is something to consider, and we are here as a resource.
Great. Thank you, Jennifer. So Jennifer, I think you had a couple of questions for me, and I certainly have some questions for you, really to continue this dialogue.
Absolutely. Tonya, one of the things that you said earlier on, one of the most important things to take away from this presentation would be that simply having a code doesn't guarantee you payment, right? You need coverage in it. You need that payment established as well. So would you be able to give an example of a situation where you might have a code, but maybe the other factors aren't really there with coding and payment as well?
Sure. Yeah, absolutely. And there are a lot of examples of, negative policies that exist even for Category 1 CPT codes, again, that have literature, there's evidence that supports their use for the intended patient population, there's society support. One example is 22857 for lumbar artificial disc. It does have some payer coverage, but there are other payers who don't cover it because there's a negative health technology assessment, for example. So really understanding those pieces, and not only the coverage guidelines from the payers, but who are the payers looking to as they're establishing their medical policies. Another example is spinal cord stimulation. There's a Humana has a negative policy for that Category 1 CPT code. And of course, as we get into really look at Category 3 CPT codes, remember that those are for new and novel technologies that are assumedly used just for tracking purposes. Now, it used to, I think the thought in the industry was that Category 3 codes were terrible to have. It was the kiss of death, quote unquote. I remember hearing from clients and the industry alike. But they do serve a purpose. And as I mentioned before, 90% of new and novel technologies have to kind of go through that step of having a Category 3 CPT code. Remember that there is payment assignment for the hospital, for the facility by CMS, but the procedure is actually carrier priced by CMS or commercial payers, but there are mechanisms to put into place to really support your clinicians or healthcare providers to make sure that they are paid and that it is covered. And as you're developing that evidence, that's going to be required for that conversion to a Category 1 CPT code. So, there's examples of Category 3 CPT codes that they usually sunset every 5 years, but that have been extended because the innovator worked very closely with the payers to make sure that they established positive guidelines. They did the studies, they put the right evidence in place, and they actually worked with the payers to make sure that they were paid appropriately. So they're not necessarily the kiss of death any longer, but it's important to really understand the resources that are going to be needed if you have a Category 3 code and if you need to go down that route. But it doesn't preclude you from having, or your providers from having, payment and coverage for that technology.
Great.
So Jennifer, I have a question for you. So what are some of the implications or considerations that innovators should have or think about when they're trying to piggyback, if you will, or use an existing code, CPT codes, for example?
I'm really glad you asked me that question because it's a very serious consideration, right? There's several things that innovators should look at. One of them being, where does that code that they want to use or think they should be using fall within the payer coverage, right? Are there existing negative coverage policies? Because that will be an uphill battle. The next thing, as we mentioned throughout several times in this presentation, specialty societies associated with that disease category for use of that code play a big role. So if they do see improper use of a code or high usage of a code, and it hasn't been really validated or verified through their society for that disease state, they can have punitive effects on that code. They could actually apply for and establish a Category 3 code, and it will create a negative relationship with that society, between the society and the innovator. So something to consider there as well, because they really should be involved with the innovator early on, so that proper code establishment and usage is validated. The other thing to consider is there is always the risk of failing an audit on the provider or facility's part, right? When they use a code and they haven't been able to substantiate use and billing of that code and they've gotten paid for it. If an audit is conducted, and that's done in several ways, audits can be based on, a high number of a certain code going in that's excessive in comparison to other peers in that space. A high number of units on a code improperly used, right? Because codes have all assigned maximum units that can be billed together. That will initiate an audit. It could be that there's a lot of errors that a facility or physician makes on a claim when using a code. That will trigger an audit. And all of these things need to be taken into consideration, because if a provider can't substantiate the medical necessity and why they use that code, there will be clawbacks. There could also be fines. There could be, licensure that's revoked, et cetera. So all of these things are important. And an example I can give you of this would be, using a billing with a CPT code for a technology that is inclusive in the definition of that CPT code of an office visit. And a physician also doesn't realize and bills for that office visit. When the audit comes, they're going to say, if you did not do something totally separate and identifiable to bill that office visit in addition to that CPT code, procedure, and device, they will claw back that E&M visit. And that's a very big one that comes into play, right? So really understanding what goes into that definition and establishment of that code is really something to think about. And then you have to think about, where that code is going to be used for and paid in all of the settings of care. You have to understand how it's reimbursed in that setting, and if it has high enough value and practice expense for that device to be used, right? For instance, if a physician purchases the technology and uses the technology in their office, but the RVUs that are associated with that CPT code are not going to be high enough to cover that provider's purchase. The RVUs could really play a role in having insufficient payment in that setting. Another example, and this is really relevant to technologies coming onto the market in today's age, is AI, artificial intelligence, and digital health, right? So these are great therapeutic and diagnostic tools, but when you're considering to use an existing CPT code that already has a work valuation associated with it, you have to understand that AI and digital health might be doing that work. So the physician isn't actually doing that work. So it's improper to use a CPT code that has, an associated work value that's not really appropriate for that technology. So that would be an inappropriate use of a code.
Yeah, I've seen that a lot, actually, Jennifer. And I think that's something that innovators in the digital health space, therapeutics and diagnostics alike, really need to think about and understand, and really work proactively with the societies if they are considering establishing a code or even using an existing CPT code. It's a great point. Thank you. Next question, what should innovators understand about CPT code use and reimbursement rules? We talked about this in the deck. Really, really important. You gave some examples. Are there additional examples of how using an incorrect CPT code caused billing or payment issues for providers that you can think of?
Yeah, so there are rules that go along with each CPT code, the overall payment methodologies, and using those codes for coverage and proper payment. And several things to consider would be something like unbundling, right? Or upcoding, improper modifier use. These are all components that again go within that definition and code establishment information, right? So we have to understand what is already included in that code. Am I billing for something that is deeper or more work value than I should be, and I don't have enough to substantiate it in my medical notes and in history in case I get audited? And then another thing that providers sometimes do, could be accidentally, is code stacking, right? And that doesn't necessarily mean that if you bill, as we gave the example with that multiple procedure reduction rule, if you bill 5 CPT codes, that you're going to get this massive payment. Because as we indicated, the status indicators of these codes, and especially in the HOPD setting or ASC setting, will have multiple reductions on each of those codes outside of the highest valued code. And using the wrong code or a higher level code, it's going to definitely trigger an audit, right? And recoupment of payments, and it could be worse. So, and it could be worse when I mean like going into the fraud and abuse category, right? So for instance, an example of this would be a psychiatrist who was fined, hundreds of thousands of dollars and permanently excluded from taking part in the Medicare and Medicaid programs because he was upcoding. What he was doing was he was billing for 30 or 60 minute face-to-face encounters. And when in reality, he was only meeting with the patients for 15 minutes or to do, medication checks. So his notes couldn't validate using those higher level codes where you would have more work associated with it, more medical decision making, et cetera. And so you could see that there really could be some serious consequences if you don't know how to use or don't use the codes properly.
Yeah, that we don't like fraud and abuse, do we, Jennifer? And innovators should be very careful about, even directing physicians, because it is ultimately the physician's decision on what codes they use. But we certainly don't want to have the OIG coming forth. What about global periods? And what are those? What are they? And what should innovators consider again when looking at, is there an existing code that could fit their technology? What about global periods? Explain.
Yeah, global periods are important because they play a role in assigning when a code can be billed and what the follow-up period for that code will consist of. So when a provider bills a CPT code, oftentimes there are days for follow-up that go along or attached to that code. For example, CPT code 14000. This definition is surgical repair of a wound on the upper body by attaching a piece of tissue from an adjacent site. The attached global period to that code, for an example, is 90 days. That means the day before the procedure and the day of the procedure count as 2 days. And then you have to follow it out 90 days after that for anything else the physician does for the payment he got on that date of service. Okay. So if the physician sees that patient back in the office and they remove sutures, or they check the wound site that they worked on, or they, had to give an antibiotic, maybe it got infected, everything that they do is included in the payment for that. So those global days are important to pay attention to, because you want to make sure that you're not billing inappropriately within that period and expecting payment or receiving payment, because that, and again, in an audit, will not pass.
Yeah. Great points.
And I know we talked about the multiple procedure reduction rule too, Tonya, but it's so important because just thinking about when a provider uses a technology and it's included into the CPT code, you really have to consider the work value associated with that, the payment level associated with that, because if there's other codes that provider bills on the same day that are subject to a multiple procedure reduction, there might not be full payment for that from a claim. So it's just something to think about. Always the provider's decision, right? To whatever codes are appropriate to use and how they can substantiate it with their notes. But it's something to consider for sure.
Absolutely. And then NCCI edits, we touched on those for a brief second in the presentation, but I think it's important for the group to understand what those are and how they affect payment and for CPT codes.
Yes. So NCCI edits, NCCI stands for National Correct Coding Initiative, and this is a guidance that CMS will release, and it helps identify which codes can or cannot be billed together on the same date of service in a physician or an outpatient setting. So basically what the goal is to provide it direction so that there's not improper payment made when 2 codes or 3 codes are billed together. Okay. So oftentimes they will identify, is the use of a modifier appropriate? If you remember the example I gave you in the earlier question about using a code and that has an office visit included in the definition of that code and payment of that code, right? If there is an office visit that is separately identifiable, not even related to what the CPT code was being used for, there might be an appropriate use of a modifier that a physician can do to bill those 2 codes together properly and receive payment for both codes. And within the NCCI system, there are edits that providers should watch for. One is called a PTP, or procedure to procedure. And really it's just identifying what is usual and customary and standard of care for codes to go together, right? Another thing to consider, and I've mentioned this earlier as well, is medically unlikely edits, or MUEs. These are the maximum units that are associated to a CPT code. This means it's an established standard of care of what CMS or AMA has, and the societies have relegated as would be standard for using or performing a procedure. So that is something that you have to pay attention to because it could, again, trigger that audit. And then there are add-on codes that are under the NCCI edits. And these are to help identify additional services or work done within that primary CPT code that help identify the additional work and additional payment that is relevant for that work. So those are some of the things that go along with NCCI edits, but very important. What codes can go on the same day and how to use them properly.
Yeah, that's very important consideration. When we think about, again, the multiple procedures that can be done the same day. So thank you for that, Jennifer. I know we have just a few more minutes and I do want to leave time for some questions, but I just want to go back to a very, again, important piece of, how do the innovators really validate and identify what are the appropriate pathways to identify and validate whether an existing CPT code is appropriate for their technology, or if they do need to go down the road of establishing their own. Let's reiterate that, if you could, Jennifer.
Yeah, I think it's important, right? So there's several factors that we should consider. One of them would be taking a look at that vignette or op note so that we can properly identify the steps that are associated for the procedure that might be defined in an existing code or might need a new code to be established to properly define. We can look at the organizations that handle coding like AAPC or American Hospital Association and what their recommendations would be. And looking at the RVUs or those work units and practice expenses that are associated with those codes. Does it match that procedure and technology? Where do the specialty societies fall with this? What are their recommendations? Has there been engagement yet with regards to that procedure and that new technology? Are there multiple codes that we should consider? Maybe there's not one. Maybe a couple of codes would go together to really properly identify the whole work value and what's being done. Is the technology assigned to a payment category that we should consider, like DME, right? Durable medical equipment. There are entities and bodies that maybe we should get validation from before we use a code within the DME sector, like the PDAC committee.
Right.
So just seeking those professional opinions, really reaching out and making sure we have the support and the validation and accreditation to be able to use the codes. It's just so important. And if there's a code that might exist, we have to take a look at, like, as you mentioned, the miscellaneous codes. Should we be using, to get proper payment because there's not payment assigned, should we be using crosswalk codes, right? To help the insurers identify our technology and what the work associated is with that technology. Just all things to consider. And again, PRIA is here. We are experts in this, is what we do all day. And we are here to help to identify, validate, help technologies get into the coding process and then move forward with payment and coverage as well.
And do it the appropriate way, right? And one thing I'll add to that, thank you, Jennifer, is the importance of proactively working with the relevant specialty societies that your technology would be subject to. That is so important when we talk about CPT, because the specialty societies play such a significant role in not only establishing new codes for new technologies, but also modifying existing language or descriptors for existing CPT codes. So thank you. I'm going to open it up for questions from the audience. We did have one question that came in through the chat, and that is there category 2 as well? There are category 2 CPT codes. However, those are used for performance measurement and tracking performance measurement. They are not required to be on the claim, and they are not a substitute for either category 1 or category 3 CPT codes. So hopefully that answers the question. And I'll open it up for anyone else who has questions, either through the chat or verbally. Going once, going twice. Okay. All right. Well, I'm going to assume that there are no additional questions, but if there are, and you need to reach us or you'd like to learn more, you want to dig in a little bit further to any of these concepts, anything we talked about today, or anything related in general to reimbursement, market access, evidence generation, our email is here and contact information, and we'd love to hear from you. Oh, there's one more question that came in. Are there any types of codes that don't have global periods? Jennifer?
The codes that we spoke about today are CPT codes, and they will have global periods attached to them most certainly. Although some CPT codes have 0-day globals, right? So it means that you can do a procedure today and tomorrow and the next day, and there's no follow-up that's included in that code. So that's something to consider. Regards to HCPCS codes, we didn't get into that too much today, but they generally won't have a global period associated with that, because that is a device or a drug, right? So it wouldn't make sense to have a global period on that. So generally they're assigned to CPT codes, and then they will range from 0 days all the way up to, I've seen them to 120 days.
Yeah. Great question. And then one last piece, I will just mention that the webinar will be made available online on demand if you would like to share it with anyone, any of your colleagues. So it will be available soon. And with that, we will adjourn. And thank you, Jennifer, for all your input. Thank you, everyone, for attending today. I hope it was valuable. And we look forward to hopefully hearing from you. Have a great day.
Thanks.
Thank you.
Bye, everybody.